And you're listening to RN's Health Report. Our email address for questions and comments is healthreport@abc.net.au. I'm Norman Swan, as usual, with Tegan Taylor. Hi, Tegan.
Hi, Norman.
Now, you've got a story this week on breastfeeding in the times of COVID.
I do. So, I mean, having a new baby is exciting, but it's often one that's really fraught with anxiety. And so it shouldn't really come as any massive surprise that that's really amplified during a pandemic. And the Australian Breastfeeding Association has put out some new research on this because their breastfeeding hotline, they've got like a 24/7 hotline staffed by volunteers, has had a real jump in the number of calls that they've had this year and a slightly different mix of calls than they'd have in a typical year.
So what did they actually find?
Right, so they had about 1,000 extra calls a month than their normal monthly average, which is around about 5,000. So a pretty big, significant jump. And they found that people were calling up with some of the same queries that they'd usually have. They're worried about their milk supply or their baby not gaining enough weight or they've got painful breasts. But there were other things that people ask about sometimes, but there was a lot more questions about it this year, like people wanting to restart breastfeeding again, either because they'd weaned or they'd been formula feeding beforehand.
Oh, really?
And yeah. So I think people were thinking that they wanted to protect their baby with the immunity that can come with breast milk, the immune boosting power of breast milk. And also they were worried about supply of formula because if you recall, early in the pandemic, there was a real problem with panic buying. Yeah. And so I think people were really concerned about supply of formula for their kids as well.
Yeah, of course. That tugs your heart there when people want to restart breastfeeding after the milk's dried up, probably.
Absolutely. And so then obviously the people who are on the other end of the phone are phone counsellors and they're volunteers, and they were sort of talking about that as well. And the other thing that people were talking about was just feeling stressed and isolated, and that they weren't able to access face-to-face health services either because they were worried about going to their GP or they just couldn't go because, and this is one that tugs at my heartstrings, a woman who had symptoms of mastitis, so a breast infection, but because she had a fever, she couldn't go to her GP because that was a COVID system and there was an overlap there. And the number of people allowed in the doctor's rooms as well. So a mum with a couple of kids can't go in because he can only have 2 people at a time.
So they weren't able to see lactation consultants face to face?
This study was done quite early in the pandemic, so March to May, and that was a real time of uncertainty and upheaval. I suspect things have gotten better since then. But I mean, this helpline service is there, and perhaps there were lactation consultants available as well. But as sort of a pre-existing telehealth service, it was probably a bit more accessible than what came online later.
And you spoke to Naomi Hull from the Breastfeeding Association.
That's right. So she's the Senior Manager of Breastfeeding Information and Research, but she's also a telephone counsellor herself. And she said that the pandemic has made what's already a really hard time for mums even harder.
The normal concerns of having a new baby just seem to be amplified, particularly for mothers that were isolated from family and friends. That lack of other adults to talk to, those visits and all the usual exciting things that happen for new mothers just weren't able to happen for those mothers.
That's Naomi Hull from the Australian Breastfeeding Association. Was there any sense that, it doesn't sound as if there was actually, but breastfeeding rates dropped during this time?
Oh, according to this study, it feels like it's quite the opposite. But the study's based on calls to the Australian Breastfeeding Association. So the implication there is people are calling because they're motivated to breastfeed. But it also maybe indicates that people were trying to breastfeed, but they couldn't also access the sorts of face-to-face services that they'd usually have. But there was a different study in Maternal and Child Nutrition Journal last month of the UK, and they interviewed even more people. It was a similar sort of study, and some of those mums, it was about 40%, said that they felt that their breastfeeding was protected due to lockdown, that it was better. But there was a pretty big chunk of women who felt that they had less support to breastfeed, and there's about a third of the women in the study felt like they stopped breastfeeding before they wanted to because they just didn't have the support available. So I think it really depends a lot on who the mum is. In that British study, mums of black and minority ethnic backgrounds were much more likely to be impacted by the pandemic and stop breastfeeding before they were ready.
So it sounds as if mothers and babies internationally have been neglected, if you like, in pandemic planning.
Well, yeah. So another expert that I spoke to for this, Carleen Gribble from Western Sydney University, she's studied this and she said she wrote advice to an emergency plan document in 2007, indicating that there isn't enough emphasis on infant feeding in these sorts of plans, and that one of the big holes is that mothers and babies need to be seen as a dyad, as a single unit, and that protecting that relationship and their ability to stay together is really key to having the ability to feed them as their mothers want to, even in times of upheaval.
Tegan, thank you.
Thanks for having me.
And Tegan will be back in the Health Report podcast to answer your questions at healthreport@abc.net.au. If you can cast your mind back to the early days of the COVID-19 pandemic, all the talk was about treatments, with President Trump asking questions about oral bleach and strongly promoting hydroxychloroquine, which is now known not to work. But things have moved on. We now know that certain anti-HIV drugs don't work either, and that the antiviral remdesivir is disappointing. And convalescent serum, that's where they got emergency use authorization in the United States, where you take the blood of people who've recovered from COVID-19, spin down the serum that contains the antibodies and give it to somebody with the infection, it doesn't seem to work either. But there are other reports that monoclonal antibodies might work, that blocking the receptor for the virus might be promising, and returning to one of our earlier reports, that the anti-parasitic medication ivermectin, we find out that that has not yet fallen out of the race. David Jans is Professor of Biochemistry and Molecular Biology at Monash University, and his group was studying ivermectin long before SARS-CoV-2 came along. Welcome to the Health Report, David.
Nice to be here, Norman. Hello.
Now, it was your colleague that did the work on the ivermectin we had on the programme, and that was in the lab. Just remind us what you found in the lab there with ivermectin.
So we've worked on ivermectin for over 10 years in the lab, and we had worked out what we thought was the mechanism. I can talk a little bit about that later if you like. But what we did when the COVID-19 epidemic started was immediately I think both of us simultaneously but independently. So my colleague Kylie Wagstaff and myself thought that ivermectin could work and should work.
So this is because the work you've been on the previous 10 years was into other microorganisms, not just parasites. You'd looked into other viruses and so on and found some effect again in the lab.
Exactly. So we'd worked on ivermectin for more than 10 years on basically other viruses, dengue, Zika, and so on. And anyway, we both thought it's going to work for COVID-19. And so we did the test in cell culture, and it came up as we expected. And so that's where we are, or that's where we were then.
And it's jumped to human studies, but has there been any animal evidence, so-called preclinical evidence, that ivermectin can work?
So there have been some studies about ivermectin, but certainly not in animals, but not for COVID-19. So ivermectin is known to be completely safe, basically, after more than 40 years of use in humans. One bad interaction in a million. And so I think people...
And this is used in the treatment of river blindness in Africa in particular.
Actually for various roundworm infections, so a whole host of them actually. And so people just basically read our paper and I think jumped straight to humans, as I think a pandemic probably warrants. And so by my account now, I think it's something like 68 randomized clinical trials running for ivermectin, and a whole bunch of other what I would call observational studies. And so, yes.
So it's running the risk of going the hydrochloroquine way, which is lots of tiny little studies that are not very well designed where you don't really quite get an answer. So when you look at a spread, I mean, how many high-quality studies are actually being done into ivermectin?
I would like to think that a number of the 68 are high-quality studies. And I should add that we ourselves have been sort of working in the last 6 months as hard as we can to get to the point of doing a clinical trial ourselves. So I would agree. I think the sort of plethora of different studies that, as you say, are not very well designed is a problem. But I think some of the studies have been quite well designed, and I think the results are starting to come out.
Showing what?
And so they show two things, I think. Number one, they show that ivermectin is safe. So as I said before, ivermectin has this amazing safety record after 40 years of use or over 40 years of use. However, it wasn't clear to me that necessarily ivermectin plus COVID-19 would be a good combination. And so I was a bit scared about, sort of adverse reactions and so on. Not a single report that I've seen in any of the studies any other
that's
study.
Comforting, but safety. But what about effectiveness? Because it's been used in two ways. One is early treatment to sort of prevent going on to COVID-19, and the other is a treatment for COVID-19, which is the disease caused by SARS-CoV-2.
Exactly.
What's the evidence showing?
So I think the evidence is positive for both, and obviously we're dependent on then the release of studies that are either randomized clinical trials or peer-reviewed publications. And so so there are a number. There's probably 6 or 7 now that I think are looking very positive. In terms of prophylaxis, so you would take ivermectin to protect you against impending infection because you're in a risk group. So a study in Egypt showed that 2 doses of ivermectin were enough to protect most, so 93% of patients who didn't have symptoms but were close family contacts of a COVID-positive patient.
And was that a randomised study?
It was a randomised study, and in the control subjects, 58% got symptoms.
Now, just get down. So you're getting positive signals, but we got positive signals out of hydroxychloroquine. But when they did large studies, like the recovery trial in Britain, which is thousands of patients in real life in the wards in Britain, hydroxychloroquine fell over, and it's fallen over in large clinical trials. So you often get a signal. It's like vitamin D in fish oil. Small, poorly conducted trials, you get positive effects of vitamin D in fish oil, and then we get larger and larger trials, they fall over. How much can we bet on this?
I'm not a betting man. I think there really is little point in presuming it's not going to work until you've shown that it doesn't work. And I think, unfortunately, there are a lot of people who keep saying there's no evidence. I think there is actually a lot of evidence to suggest, yes, you should do the big trial. And I think all of the positive results such as the one I just talked about, they are actually much, much better than any sort of preliminary or small study result for, I think, hydroxychloroquine or remdesivir or anything else that I've seen.
And unfortunately, with the second wave in Europe, they might get a chance to test it.
So there are randomized clinical trials in Europe, in Spain, in France, and so on. So I think we're all just waiting for them to start to release their results. And when they do, we'll know one way or another, of course. But I think, as you say, the big study is what you need to do. But in the meantime, there's lots of people in hospital that actually need a solution. So I think you have to navigate, the extreme urgency of the situation, the right way. And at some point, I think, you can talk about randomized clinical trials forever. When do you have enough? Well, you never do, I suppose.
David, we'll follow this up with interest. Thanks for joining us.
No problem. Thank you, Norman. Bye.
David Jans is Professor of Biochemistry and Molecular Biology at Monash University in Melbourne.